Okay, good afternoon, everyone, to the group here in Montreal, and welcome to the online CSO community. Many thanks for joining this plenary session with the annual leadership meeting live from Montreal, where we don't have snow this year. We have some damp drizzle instead. My name's Chris Booth. I'm an oncologist in Kingston and one of the organizers of this event. We're very grateful for people being here. I'm going to kick off this plenary session with an overview of activities from Common Sense Oncology over the last year. And then we'll be handing over to our moderator, Dr. Ian Tannick, who will introduce our three plenary keynote speakers. And we're in for a real treat this afternoon. Thank you, Craig. Just to acknowledge the people who have traveled, we have about 50 people here from 18 different countries worldwide. We're very grateful for all of them coming from far and wide, and very grateful for those of you around the world who are listening live on Zoom. I wanted to acknowledge the Ontario Institute of Cancer Research has provided funding to help support this meeting, as well as other agencies and philanthropic sources that have continued to support the work of Common Sense Oncology over the last 3 years. So I thought we'd take a little bit of a walk briefly down memory lane to see, is it true that Ian Tannick is looking younger rather than older every year? And I think it might be true. So this is going back now 3 years, the original founding meeting in Kingston, Ontario, where 30 of us spent 3 vigorous days discussing what we thought were the greatest challenges in our field and which were some of the problems that we were going to tackle and how we were going to organize ourselves. And then 2 years ago, we gathered at a 1980s themed hotel in Montreal, and you can see the color theme is still in early 1980s. And at that point, we decided what we're going to focus on, and that led to the planning of our strategic priorities. And then last year, the third meeting here at the Alt Hotel in Montreal, where we've gathered again, and we talked about things related to communication, engagement, and action. And here we are for the 4th annual meeting of the CSO leadership. Going back 3 years, what's I think remarkable is the Common Sense Oncology Manifesto, as it's been called, still rings very true 3 years later. I think the mission and the vision are still highly relevant. I think it's what motivates all of us around the world who are very committed to making things better for patients and their families. And we continue to work very hard to move things forward. Our guiding principles, I think, have held up very well over the last 3 years, and this really forms the bedrock of the work that we all do across the clinical care, delivery space, the research, education, and policy ecosystems. And we heard earlier from Henny Scrowcroft, who led the working group on our communication strategy, and we now have a new CSO elevator pitch. So I'm not in an elevator, but I'm going to share this with the audience here in Montreal. And this group actually helped shape this 1 year ago. And for the audience joining us virtually, Common Sense Oncology believes that healthcare systems can do even better for people with cancer. Thanks to decades of investment, research into cancer has transformed countless lives. But despite this progress, newer treatments can come with frustratingly uncertain benefits for what matters most to people with cancer: living longer with a better quality of life. At the same time, too many people around the world cannot afford or do not have access to long-proven effective cancer treatments. CSO is a global network of oncologists, researchers, advocates, and others who work collaboratively across the cancer community to focus research, care, and policy around what matters most to people with cancer, empower people with cancer to make treatment decisions that best fit their goals and values, and ensure cancer care systems are economically sustainable and focused on delivering human-centered care using the best available evidence. Together, we put outcomes that matter at the center of the cancer community. I think this really rings true for all the work we collectively do across our various health systems globally to move things forward. And so going back to why did this global initiative launch? Now, it came from, I think, a very deep place of caring. All of us who've had the privilege to look after patients with cancer or provide service in one way or the other in the cancer system, care deeply about the people we have the privilege of looking after, and a belief that we can improve things. We do many things well, but we can improve and do better in some regards. We want to advocate for what's best in our field and what's working well. And increasingly, we're unwilling to remain silent on some of the problems that have been well recognized by all of our community for a long time. And it was time to move beyond just pointing out problems or being critical of problems and to be solution focused. And that's where the hard work really begins. We wanted to set an example for the next generation in our field to show them that there was a path and a career paradigm where they could tackle some of these big problems, and to create a place where we could have open communication, reflection, self-humility, and change to make things better. This was really a founding premise at our first meeting in Kingston now 3 years ago. CSO must be about more than just publishing papers. This initiative is fundamentally about changing cultures, mindsets, and systems to make things better for patients. And I think that still rings true 3 years later. Our leadership structure is anchored around 4 project teams. Each project team has co-leads. We have a clinical trials team, an education team, patient priorities team, and a health systems team. That co-leadership structure is joined by about 10 or 15 members of each project team, which includes clinicians, academics, patients, advocates, and other people with lived experience. The work is supported by our fellows. We've had a very successful and exciting CSO fellowship program, which brings young oncologists from around the world to work with the CSO leadership team. And we have 3 amazing staff that help drive everything that we do forward. As mentioned, the engines of change within Common Sense Oncology are the 4 teams, and this is supported by collaborations with groups around the world. I just want to draw attention to the fellowship program and encourage young oncologists worldwide to consider applying to be a CSO fellow, and we've had a wonderful collaboration and partnership with the EORTC over the last couple of years, and in fact now have a joint fellowship hosted by CSO and EORTC. But to get to one of the most important questions I'm asked all the time is, what's it with ice fishing and Common Sense Oncology? And is this like really a thing? So I show this picture quite often. This is when Bishal Gawali and his family literally landed in Canada. And the first thing we did was we actually took them ice fishing. And my farmer friend who hosted us had actually caught a fish earlier in the day. And Bishal still thinks that he caught that huge pike that our farmer friend had actually caught earlier. But we're also about training the next generation. And so our current fellow, Dr. Sam Stevens from Australia, has really been celebrating ice fishing culture this year with his family and children. You can see him out ice fishing on Lake Ontario and even going for a cross-country ski while his supervisor provided childcare. Not sure how that power dynamic got reversed. It's supposed to be the other way around, but actually Sam looks after my kids sometimes too, even though they're much older. Just to remind our listeners and those in the room, this is our strategic plan that we have 4 goals. This emerged after a collaborative process 2 years ago. We have a goal to improve how we run clinical trials. We want to do a better job educating the current and next generation of oncologists around core principles. We want to improve how oncologists communicate to patients to empower them to make the treatment decision that's best for them. And we want health systems and policies aligned to deliver cancer care that makes a big difference. So at this current meeting in Montreal, we're focusing on how to implement some of the products that we've already developed to have real-world change, how we can better engage the broad community of stakeholders, including our members and those with lived experience, and to really focus on our core ethos when we launched 3 years ago about changing mindsets and the practice of oncology. So just to highlight some of the work that's been done over the last year by the 4 very busy project teams, Ian Tannick and Bishal Gawali leading the RCT team have been busy implementing the RCT checklist, which was published just over a year ago, working on a guidance document for discussants at conferences, doing work in quality of life jointly with the ORTC to come up with perhaps a new way of conceptualizing and reporting quality of life that augments current practices. We have work understanding how chronic toxicities affect our patients, and these toxicities can be deeply challenging for our patients and are not often measured in many current clinical trials, and then branching into single-arm trials. And just to show some of the highlights, so again, we're all about action and implementation, and so the CSO checklist for RCTs was published just over a year ago, and we were very pleased just a few months ago when 8 journals in the Lancet family had published an editorial that largely supported, adopted, and endorsed many of the core CSO principles at the time of revisions for manuscripts submitted to these journals. Just over a year ago, Dr. Eisenhower and the RCT project team proposed how discussants at major conferences might consider approaching the review and discussion of phase 3 practice-changing trials. And we've had strong and very deep partnerships with ASCO leadership. And we'll hear tomorrow from ASCO President, Dr. Eric Small, about some exciting developments at this year's annual meeting. And in fact, some of these checklist items are being very much incorporated into the 2026 meeting. We're very excited about that, and we look forward to hearing more from Dr. Small about this tomorrow. And continuing our partnership of work with EORTC, we have the framework for measuring quality of life in the context of advanced cancer, and this will be followed very soon by an ongoing companion paper looking at how we can improve measurement and reporting of quality of life in the adjuvant context. Shifting to the patient priorities team, led by Michelle Tregear and Chris Jackson. They've been working very hard with patient advocacy groups around the world to identify a framework, values to action framework for what people with lived experience look for in the design and conduct of a randomized trial. We have a 5 questions project where we're going directly to people with lived experience and clinicians to learn if we were to provide a short tool to guide decision-making and conversations in clinic, what are the most important questions that stakeholders think should be addressed in that consultation room? We've done engagement with patient advocacy groups around the world, and we're developing a new program, Learning from Those Left Behind, engaging and learning with people who have lost a loved one to cancer to understand what worked well in the system and where could we perhaps make things better in the future. And so the Values to Action Framework is just recently published as a preprint with JNCI, will be fully published in the near future. And partnering with the Canadian Drug Agency, Common Sense Oncology has launched a global study to understand which questions patients, families, and care providers think are the most important to frame discussions in the clinic. Our education team is led by Heide Vertusco-Aguirre, one of our former CSO fellows, and Scott Barry. They are nearing the end of a very detailed process, reviewing oncology training program curricula around the world and completing a Delphi to understand which core competencies and domains should be put forward into training programs to equip the next generation of oncologists with the tools they need to follow some of the principles that we write about in the CSO frameworks. There's been a lot of educational efforts too with journal clubs and webinars, and we've been very fortunate to partner with major conferences around the world to have educational sessions and satellite symposia to engage the broad community in talking about CSO topics. And as you can see here, many of our members have led and attended these sessions globally, from Sub-Saharan Africa to Brazil to Europe. And we're very excited at the annual ASCO meeting this June in Chicago. There's 2 educational sessions that are highly relevant to the CSO initiative. The first one is focusing on value, access, and quality care. Can we have it all? And the speakers, many of whom are very involved in this initiative, will tackle this topic. And another educational session that we've developed very closely with the Scientific and Education Planning Committee at ASCO is Innovation, Evidence, Compassion, and Hope, Delivering Outcomes That Matter. And so we're looking forward to those as a way to engage with the community and certainly encourage members and interested groups to please attend that and engage with us before and afterwards. And the educational team has been busy having webinars, it seems like almost every couple of weeks around the world, and engaging with our partners. In a few minutes, we're going to hear from one of our plenary keynote speakers, Professor Richard Sullivan, who co-led what I think was one of the most important publications in our field in the last year, which is The Human Crisis in Cancer, a Lancet Oncology Commission. And I think the figure, as shown on the screen, really conceptualizes so much of what CSO is all about. And we can see the human-centered cancer care is comprised of 4 core domains. The domain of biomedical care, which I think obviously is fundamental, but perhaps has been overly emphasized at the expense of the other core domains, and we need to ensure that we also pay attention to the psychosocial and emotional support, compassionate communication, and the shared decision-making and patient autonomy domains. And we're very pleased, and this is a tribute to the educational work led by Scott and Heide, to see that within this Lancet Oncology Commission, the core competency and curricular review led by the CSO education project team was highlighted as an important initiative moving forward to change training programs. The Health Systems and Policy team, co-led by Manju Sengar and Brooke Wilson, has been busy looking at essential medicine list at the national level, how they compare to burdens of disease, and the WHO core essential medicine list, which a number of us are quite involved in as policy advisors to the WHO. We have a program which is learning how we can better support decision-making for patients and families, the Binder program led by our current CSO fellow, Sam Stevens. We're doing work to understand globally how regulators, patients, and physicians view different endpoints. And we're also trying to influence how we change delivery of care at the system level. And just to highlight how conversations are really shifting over the last number of years, is every 2 years, the WHO Essential Medicine List is updated. And this past year, when it was updated, there were some very important new cancer medicines added to this document. But there's also these very important comments embedded in the scientific report, identifying that having access to these medicines in health systems around the world is a really essential aspect. It's one thing just to run a trial and have evidence that treatment works, but we fail patients globally if we don't take efforts to ensure that they're broadly available. And this leads to a quote from one of our own traveling oncologists. Professor Chris Jackson on a CSO World Tour had this line, which I think encapsulates this sentiment. If innovation is the heart of oncology, then access must be its conscience. The Health Systems and Policy team, together with the Patient Priorities team, has also done a review of some common recommendations that are perhaps well-meaning but might have unintended consequences for patients. And again, we're going to leverage this to work with education platforms to ensure that patients and families are getting information they need during their chemotherapy journey. And finally, at the policy level, a number of us are working on advocating for non-pharmacologic entities to move forward. And this includes a number of very expensive complex molecules, exorcizumab, palatuzumab, the extraordinarily priced geriatriximab, and Symptomab. And so this speaks to the fact that we need to look, we need to advocate for access to cancer medicines. These system-level providing these system-level interventions that are non-pharmacologic are also very important for patients. Over the last year, we spent a lot of effort to better understand how we can improve how we serve our members. And so there was a member engagement survey, and we had suggestions about how to improve engagement and opportunities for members globally. And that led to us launching the CSO regional hubs, which we'll hear more about over the next couple of days. We heard that we need to do a more regular and better job with communication. And so we started a monthly newsletter, and we're having regular webinars and satellite meetings at major cancer conferences around the world so we can engage with our community more broadly. We want to provide better value to our members. We want to continue to focus on advocacy with a patient-centered lens and outreach and making everyone feel welcome, because the challenges in our field are very large and we collectively need to work together to overcome these. The communications plan identified really 3 key objectives, which we're going to work on: increase the visibility and reach of the CSO brand and its key outputs among stakeholders, demonstrate the value of CSO membership and promote opportunities to join and participate, demonstrate the impact of Common Sense Oncology as activities, and encourage partnerships. And so this has led to a list of some key priorities, which will be fleshed out over the next couple of days. How we can actually implement the many outputs we've had over the last 3 years to affect change, how we can implement our communication and membership expansion program, stakeholder engagement, build more partnerships, and continue with the regional hub expansion. And so in closing, I think that when we launched this initiative 3 years ago in a small country town in Eastern Ontario, we really had no idea how much energy and the explosive interest that this would generate. And I think in hindsight, it's resonated for a number of reasons. I think this is an initiative grounded in a sense of purpose and shared values. with authenticity. It's built around people who care and want to make a difference. It's a recognition that we do things, very many things well, but there's room for improvement, and we want to collaborate broadly. And I'll just share this word cloud that was made last year when CSO members were asked to list the 3 words that best summarize to them common sense oncology. And I think we can all feel, quite proud looking at this word map that these are really overlapping very well with our core values when we launched 3 years ago. And with that, I'll close. Thanks for the opportunity to give this update for the people here in Montreal. For our listeners online, I'm going to hand over to our moderator for the plenary session, Dr. Ian Tannock. As Ian makes his way to the stage, I don't think he needs much introduction. Ian is an emeritus professor of medical oncology from the Princess Margaret Cancer Center. He changed practice in prostate cancer and in breast cancer for many years as a trialist and a deep thinker in health systems and policy work. And he was the first medical oncologist that I did clinic with and had a profound impact on me as I made a last-minute career detour and decided to become a medical oncologist after just 2 days of clinic. With that, I'll hand over to Dr. Tannock.
Chris, before we start the next session, I'd like to state from all of us that this was predominantly your baby, it's your child, and it's grown magnificently over the last few years. And it's really due mainly to your leadership that that's happened. And we're all very, very grateful to you for that. And so congratulations on starting this and what's happened since. Richard is on screen. Richard, good day. I hope you're safe despite wherever you might be. It's rumored that you stowed away on the Artemis mission, but that could well have happened. So Richard, I've known for a long time. He's the director of the Institute of Cancer Policy, the director of the Center for Conflict and Health Research, and a professor of cancer and global health at King's College London. He's also an advisor to the World Health Organization and to several other major organizations worldwide, including NATO organizations. And Richard is going to talk to us today, if I can get his exact title here, but it's really due to the human crisis in cancer, which I think was the subject of a recent Lancet commission that you chaired. So Richard.
Ian, thank you very, very much indeed. Everybody, sorry I can't be with you. Unfortunately, I'm stuck in foreign lands. Can I just double check you can hear me and you can see the slides?
Yes.
Before I wade in. Good. Thanks so much, Ian. Okay. Human crisis in cancer. A rather large topic, and I'm going to try and break it into sort of 2 easily digestible pieces. First, we'll just talk a little bit about the crises that are going on around the world, and then really to focus on the solutions. I just want to recognize, before I wade into sort of very generic sort of geopolitical and global issues, that with this sort of slightly amusing vignette from Britain, that for many people, life is a massive struggle and they live day-to-day crises. 40% of our global population live on less than $6 a day, and 1 in 10 live in absolute poverty. So we're here talking about, oncology drugs and delivery of care and research, which is a very, very far reality from most of these individuals. Most of what I'm going to draw on today comes from, as Chris said, and thanks very much for the kind comments, Chris, on the Lancet Oncology Commission we published, but also on something which will be coming out later on this year, which is we've been working on the World Bank's cancer strategy, basically the cancer strategy for what will be the Bretton Woods institutions in terms of their financing, and I'll talk a little bit more about that later. That's a relatively big deal, I think. Man of the moment, we are in a new world for health, and this is the reason why we are in a new world for health. The impact of the Trump presidency, obviously, we didn't know when CSO started this was going to happen, has been absolutely dramatic and in many cases catastrophic. We're talking about nearly a 60% decline in foreign aid. The impact globally in terms of military has caused a lot of countries now to slash their overseas development assistance and move it into essentially defense spending. And what that's essentially meant is that countries are being left to their own devices. And as the money has vaporized from the traditional programs around infectious diseases, child and maternal health. They've had to backfill that with NCD funding, and that includes cancer funding. And the problem is as well that the America First Global Health Strategy is also heavily securitized, which means they're now in a full-scale contestation with China. And China hasn't been standing still either. It's been massively restructuring its health and development. The reality is that we've been seeing a huge movement of economic and political power towards China over the last 20 years. You'll all know that China is becoming an absolute superpower in oncology drug development and oncology generally. What's not known is that they're moving into human resource development and end-to-end chain suppliers around the world. And a paper we published recently in JGO kind of gives that at least the background of just how seismic things are going to be. What we don't really know at the moment is what this is going to mean for the global economy, whether they're going to be free riders, whether this is going to be a global public good, or whether we're going to end up in a full-scale fight. And there's a real concern here that health is now becoming a very heavily contested area. And between the USA and China, health is going to become increasingly securitized. And the problem for me, and I guess for lots of others who work in this particular level, is we're noticing a massive unwillingness for many organizations, including the WHO, to face the reality of where we live now. And by the way, we are not going back to the old days. There's a need for huge reform. It's interesting that the BRIC countries have taken a lot of the leeway here in terms of moving the political discourse forward. But I have to say, I think from a Western perspective, we're very slow off the mark, and many of the major global health institutions are still highly fossilized in their thinking around this. Debt is also a larger and more complex problem. I think I talked about this last time, and it's just got worse since we've last talked. Sub-Saharan African countries in particular, and it's not just the size of the debt. There are a huge number of debt holders now. So these are private bond holders. China holds debt, bilateral Paris Club, Bretton Woods institution. And the problem is every time one of these groups gives debt relief to an African country, that debt relief is used essentially to pay off the debt for another debtor. So it doesn't go into health and education. And what we've been seeing is this extraordinary climb in basically debt to GDP ratios. And again, this doesn't just make the fiscal space for national control plans disappear, it makes the space for health generally disappear. The impact of conflict, crisis, and fragility, as you'll all well know, is just gaining ground. These really two disturbing maps, again, unfortunately, of sub-Saharan Africa, 2005 to 2024, indicate the level and intensity of armed conflict that's occurring. And it's not just the arc of instability across the Sahel here, it's spreading south, and it's, of course, right up in the north now. But as everyone knows, this is a global problem. We have the Middle East on fire again as well, Iran and Gaza. We've got the narco wars triggering enormous changes in Mexico. And there are many countries now who are over their carrying capacity, like Bangladesh, for which NATO projections are in the next 20 years that they're going to have essentially catastrophic living conditions. The effect of all of this, of course, is to change dramatically what we're seeing in terms of therapeutic geographies. And what we mean therapeutic geographies is where care is delivered and how patients move to access care. And a lot of this work, led by people like Max Skelton from the American University of Iraq, has been done in the Middle East. Increasingly, people are starting to look at this in sub-Saharan Africa and Latin America and seeing these extraordinarily complex dynamic movements as patients and families seek out care. But again, a lot of this is an unavoidable consequence of what we're seeing in terms of the sort of geopolitical crises. Another thing we highlighted in the Commission was that, to a certain extent, technology has now become more important than people. And it's an odd thing to say because, of course, we'd all do our jobs, whether it's surgery, radiotherapy, diagnostics, good systemic therapy, because of the tools we have. So in one sense, the glass is half full and getting fuller because there's more and more technologies with good clinically meaningful benefit coming into the market. But the problem is, at the other end now, we have systems almost entirely geared to the commercial determinants. In other words, money is the major driver of public policy. So whilst we might think about global public goods and systems being developed under the global public good aegis, the reality is when you look at systems around the world, and this includes high-income systems, the commercial determinants and mercantilism is now becoming one of the dominant drivers of how public policy operates and how politicians work. So what does this all mean? Well, we're seeing increasing dehumanization. There are a whole range of indicators that we look at for dehumanization. They're all going in the wrong direction. None of the SDG goals will be met. The view is now that universal health coverage or progressive universalism is dead in the water. And frankly, when you operate in the kind of global health sort of macro level, there's not enough cheer at the moment going on there because people just simply don't know where to go. We're also seeing rising global risk. All indicators are flashing red. And this is sort of related to this contracting economic headroom, which is making it harder and harder for countries to deliver basic services, never mind more advanced services like surgery. And so we have this really odd situation. When you stand back, of course, you know, this huge bag of new technologies that we're seeing, new approaches in general health systems, in cancer care, has just grown and grown and grown. But there's a sense that the health systems and welfare systems are being hollowed out wherever you look at. So welfare systems simply not improving. And also what we're seeing is more and more health systems with moral distress, burnout of clinicians, etc. It sounds like it's real hyperbole here, but it's interesting because Edward Gibbon, when he wrote The Decline and Fall of the Roman Empire, came up with this kind of list which would indicate that we're in, you know, as a society, we're in significant problem. And you only have to kind of run your eye down this list to realize that in a lot of places now we are ticking the boxes in this. So you can understand, I guess, why a lot of people are seeming extremely nervous about where health and global development is going to fit in a world which is starting to feel a bit like the decline and fall. And I have to say, you can't help but miss the Cold War. And my word, I know we used to give Ronald Reagan a hard time for being not that bright, but goodness, you know, we'd welcome him back tomorrow if he wanted to come back from, you know, the other side. The Coming Anarchy was written in 1994, and Robert Kaplan basically said, look, you know, we had our best years during the Cold War, and the following things are going to happen over the next 25 years. Everybody who works in my world at the moment is reading this book again because too many of the things he predicted are coming right. But I think the important thing to make here is by understanding what the problem is, you can actually move into doing something about it. So where can we make a better way forward? Chris mentioned changing culture. The first biggest problem is around money. No matter how we look at it, it's about turning things around and talking about global public goods and not about making profits. I think in terms about improving the culture of practices, it's not enough just to focus on social conditions. Within the Commission, we made the point that people live within systems which are politics, that have economics around them. And this is really a political economy problem rather than a pure changing culture problem. There's a lovely section written by Dara Trapani on the medical education around this and how we might change culture. But I think Chris is bang on. Culture change is necessary. Realism. Different worlds require different factors. This is how we were all brought up. Single site specific cancers, unselected. If you're lucky enough to live in a resource plenty environment, a high income country, or you've got money and you come from a lower middle income country, you can expect your cancer to be treated like this. But I'm going to be absolutely blunt with you. The idea that we should be talking about places like Mali or Chad or Uruguay having access to ROS1 or ALK inhibitors at the stage of development they're at is just an absolute impossibility. And it's a real problem in the way we're considering things at the moment. So for many countries at the moment, we're literally talking about putting in basic 101 services along these sorts of lines. And I'll come back to this factor more in a minute when we talk about what the World Bank's thinking around this. The other thing is the changing R&D and ecosystem around innovation. Improving the value offering comes up again and again and again. There's a huge amount of literature coming out now showing what massive cost opportunity there is if we either accept too higher prices and or letting in technologies with suboptimal clinically meaningful benefit. We had the work from the LSC looking at England and Wales, and that was a horrifying amount of money. This has just come back looking at Colombia and Dominican Republic, same sort of findings. So there's a real need here to get hold of this cost opportunity problem, because every pound that we spend or dollar we spend wasted within oncology care could be going somewhere else in the health system. Low value care is also becoming a really major issue. And this is a fantastic report that Niels Wilkin and Tom Hofmeister did, just looking at the data from countries that we can really put hand on heart on. And I recommend you have a look at it. This data in it is really quite horrifying. Massive overuse, massive underuse, very few countries using drugs and technologies at the level they should be using. The big issue, I think, is the second translational gap. Basically, the Australians published this fantastic report recently, and they said we fund discovery and we abandon the journey. And we have a huge deficit at the moment between all the discovery work we're doing, all the biopharmaceutical innovation, and the ability to properly put these in a sustainable and affordable ways into society. I think managing public and political narratives as well becoming increasingly important. We're working at the moment with the Brazilian Ministry of Health because of these massive use of courts to access cancer drugs. This is happening across the world at the moment, where more and more people expect to access the highest, most expensive technologies, and if they can't access them, they're going to the courts to access them. Context-specific value and thresholds. There's some fantastic work that Estro Hero are doing around this, but a lot more hard-nosed thinking needs to be done around what we mean by value-based assessments and how they are made context-specific around the world. Too many of these frameworks are just simply transported from high-income countries to middle-income settings, and they don't translate well. And then finally, within the narratives, we're seeing a huge rise in disinformation that is essentially affecting policy and politics, a huge amount of propaganda which is being directed at the general public. I can talk to Cows Come Home on Grand Galleria. That's the most egregious examples recently, but this is just, again, getting worse and worse looking at the indicators. So really the final few slides here, the changing the finances system. I can't talk in too great a detail about what we're going to say in the World Bank report because it has quite substantial impact. And it's interesting because, of course, now the Chinese Development Bank and want to talk about how this is going to alter their lending. We've traditionally focused very much on the economics of payment systems, models, pricing around pharmaceuticals, pricing around high value non-medical technologies. But really, that's a very tactical area. I think looking forward, there's going to be a much harder nosed approach looking at health systems with cancer integrated into this. There's going to be a much stronger view on sequential financing. In other words, only financing what absolutely makes sense in fragile countries which are going to require IDA grants all the way through to the more sophisticated loans. Essentially, reality stratified financing. It'll make some people very happy. It'll make some people very unhappy. A lot of the financing, I think, is going to have to be linked to technical reform. At the moment, when you look at many countries, it's not the money that's the problem, it's how it's used. Planning and forecasting is disaster, budgeting and execution is disaster, etc. This means a lot of NCPs, I suspect, are going to have to be reformulated in the next decade. What we see is a lot of this isomorphic mimicry. In other words, people making their national cancer plans based on what they think they should have rather than what the capacity and capability of the system allows. And the final thing is, obviously, there's absolute mandation for digital intelligence systems, registries, economics, etc. It's absolutely appalling how glacial we've been in moving this on in the global economy. And so financing perspective at the moment, most countries, unfortunately, are down at this end of things, very passive, poorly aligned, budget or fee for service. We're looking to move them around. This improves the resilience to future shocks and crises, reduces the friction, and most importantly, it's about building workforce as well. And this is one of the things we make a big deal about in the World Bank. It's very easy to fund equipment and technologies and other forms of recurrent non-human resources. It's really difficult to build workforce and retain them. And also to approach cancer as a development channel. This publication came out, a year ago? Michelle Coleman, 50 years of England and Wales. And what it shows is engineering cancer services takes decades. Innovations only deliver if systems work, and it really requires end-to-end engineering. And I think we just have to look at cancer not as a technical challenge, but as a development challenge. So finally, Chris said, look, if you're not coming along, I'm going to send this to Beirut. And so I've been using this religiously, Chris. It's a mouse spray that instantly transforms you into living the fantasy of Canada. I've tried it. It hasn't worked. Unfortunately, to be honest with you, I feel a little bit like this is one of my relatives who lives nearby, and this is his plaque from the 18th century, and he was described as a libertine, opium eater, drunkard, duelist, gambler, and wastrel, which I suspect is probably more my territory for the future. I don't think I can ever be Canadian. Huge thanks to everybody, particularly to Chris and all the work, and thanks very much, Ian, for that very kind introduction. And just to American colleagues there, I think George W. Bush is still alive. Maybe you'd like to bring him back. He may be open for another term. Thanks so much.
So since Richard is on remote and the topics of the talks are different, I think we'll take a few questions from the floor. And Craig is taking around the microphone. And he would like to start. It was a little bit depressing, but very realistic. Questions? Yeah. Tito.
Hey, Richard, it's Tito. Yeah, so I agree. It was depressing. How about some good news? Seriously.
Good news. Okay, in crisis there's opportunity. To be blunt with you, everyone's been kind of moving along, Tito, and there's been very little reform. I have no sympathy for a lot of the cuts to the WHO, for example. I think it's been in desperate need for reform for years. I think a lot of the global health institutes have been desperately needing reform. I think there's too much colonialism in the way Gavi and Global Fund works. And I think if people can grasp the opportunity, this is a good moment to make health central and do sensible long-term planning, putting your money where your mouth is, which is going to actually move the dial. We have poured billions into sub-Saharan Africa. And I sit there with my NATO colleagues doing the analysis, and it's just, we ask the question, where's it all gone? Sorry, that's the reality. So the good news is actually in crisis, sometimes this is what you need to get people to focus on what's necessary. And frankly, Mohamed Pate, the Nigerian health minister, said it correct recently when he said, look, we're on our own. I think a lot of the dependency on aid, etc., was unnecessary. So that's, I think, from my perspective, is the good news.
Felipe?
Hi, Richard. Great to hear and see you again. So, Richard, my point too is that we are seeing the decline of multilateralism and also the UN agents as well, as you stated firmly. So, and we've been seeing also the economic blocs reorganizing themselves. So, European Union making agreements with Latin America after 10 years of tentative agreements, and the same for Southeast Asia. So, how do you see a reshape of this political agenda and blocks, and how this will probably or not reshape funding for public health? Because this is an issue here. We see political agreements, but not necessarily funding coming or being reoriented. As far as we see, they're just more and more focused on their own country's internal policy. So that's my take to you about investments and how this policy might be changed.
Yeah, I mean, we could hear a long discussion about what multilateralism has meant and what overseas development has actually meant for the global health architecture. I think in its time, it was the right thing to do. And I wasn't being funny. I think George W. Bush, despite many issues, did a fantastic job putting PEPFAR together. I mean, it was an outstanding piece of global health initiative. But like most things have moved on. And I think for countries, I think particularly Latin American, I've spent a lot of time with your colleagues in Brazil, reorientating your way from constant dependency on the USA is going to be important. And I'm not being funny, China is the other big beast in the block. And I think when it comes to kind of health technologies, bilateral funding, workforce development, different sorts of relationships have to be built. Brazil rebuilding with Europe, rebuilding with China. And I think the opportunity is now opening up to do that as long as we don't get into some massive conflagration.
Any other questions? Okay, if not, Richard, thank you. Hope to see you back in normal areas soon.
Great to see you, Ian. Thanks, everybody.
And I'd now like to invite Fidel to come up and talk to us. Fidel is a consultant clinical and radiation oncologist, Fidel Rubagumya, in Rwanda at the teaching hospital there. And he sort of transcends from policy to clinical practice. And he's going to talk about cancer policy in Rwanda. Fidel.
Good afternoon or good evening, and good morning for others that are probably watching across other parts of the world. After that depressing talk,
You're going to cheer us up.
I hope this one is going to cheer us up. Mine is simple. I just want to share with you some of the cancer policies in Rwanda, and I believe that can be shared with other countries that are similar to Rwanda, that I think align well with CSO pillars. And to me, this is something I've always said in this meeting. I think LMICs actually the natural adopter of CSO, because we don't have the luxury to spend the little resources that we have to interventions that are not meaningful. So I'll only share with you the 5 policies that Rwanda has taken that I think have shaped how cancer care is currently in the country. Before that, I wanted to share with you where we come from. In 2011, the country had no dedicated cancer center. There was no radiation therapy in the country, no medical oncology services. There was no trained oncologists in the country, and no cancer drugs in the country. And that is a country that had about 11 million that time. We currently 14 million, and we're seeing about 10,000 cancer cases in the country, with cervical cancer leading as one of the top cancers in the country, and still is even right now. So Paul Pharma is the one who said this, said cancer care is not a luxury, but it's a human right. So I think that Rwanda understood that early on since 2011. So policy number 1 I'm going to talk about is the universal health coverage. So we have a health system where most of our population are covered by national health insurance, known as Mutuelle de Santé. It covers about 90% of the Rwandans. And the way it works is that the scheme pays 90% of the medical bill, and then the patient pays copay 10% of the medical bill. And even that 10% is really as an encouragement of someone to be participant in the way they're taken care of. But the annual premium is really low, as you can see. And the government has put in innovative ways to collect some of the funds. And one way that you might find probably applicable in other settings is that every traffic fine that we get, some percentage, 50% goes to the fund. And the other innovative ways that the government is trying to find the funds to cater for that. And the cancer care is covered by the CBHI from all the start, screening up to the survivorship. So it covers everything. Until last year, we didn't have cancer drugs on the CBHI, but since July last year, over 50 drugs, close to 50 drugs now have been added to the CBHI, and our patients are getting treated irrespective of the economical level of the patient. And I think this aligns well with a CSO strategic focus of equity and access. Another policy that also kind of changed the way cancer care is delivered in Rwanda is the cervical cancer elimination in the country. We align well with WHO framework, which is envisioning to eliminate cervical cancer globally by 2030. And the country has actually even made strategic decision to do this by 2027. That is next year. It's actually, when I was doing this talk, it was actually frightening that it's next year, which is like a few months from now. But as per WHO, the plan is to have 90% of HPV vaccination with 70% of screening with a high-performance HPV test, and also 90% of those with precancerous lesion or invasive cancers being treated. As of now, Rwanda has achieved the HPV vaccination part, where 95% of eligible girls are now vaccinated in the country. We're still a little bit below in terms of screening, and also 70% now of those that are screened at least treated. So this, again, I think aligns well with CSO focus on equity and access. The third policy is evidence-based drug formulary. When we were coming up with the drugs that need to be covered by CBHI, of course, the question always comes out, if you have $1, how do you spend it? And ours was to apply CSO policy. And what we did was that drugs that have benefit are the ones that are going to be put on the formulary. So if you had to put 50 drugs only, you understand that you're not going to add a drug that doesn't really improve OS or the quality of life of patients. So for this, we added drugs that really target the early stages, so treat the curable. But even for palliative care, the first-line chemo for metastatic disease only if there is OS benefit or the quality of life benefit. So second lines where there is no evidence of the two major endpoints were not considered for the drugs to be added on the formulary. Policy number 4 is palliative care. As you understand, in many LMICs, so we still see patients showing up or coming to us with advanced stages, so stage 3, stage 4. And unfortunately, as you might know, most of these are not going to be curable. And some of them, as I said earlier, we don't have the luxury to have the second, third, and fourth, and fifth lines as people in HICs have. So at the end of the day, some of these, we end up really changing goals of care, which is you go to palliative care or best supportive care. And having limited centers and limited workforce, you can't put this centrally. So we have now trained community health workers and also the frontline nurses to be the frontline in terms of palliative care. So now patients who are in those stages, they end up going to the community to be taken care of those two cadres, but also the central referral or communication channels are also open. So this also aligns well with the patient-centered outcomes as a CSO focus. Fifth and last for this talk is training the oncology workforce. As I said, 2011, we didn't have any trained medical oncologists, clinical oncologists, or radiation oncologists, or any oncologist. And the government policy was to, if you send someone to go to study abroad, I think it's in literature, it's known that one of the cause of brain drain is actually training abroad. So we are trying to divert from that, and we started our own oncology training program, which started 2 years ago. And as of now, we have graduated 3 medical oncologists and 2 others are in training, and we hope that the numbers are going to increase. And by doing that, we hope that, of course, if you want to improve care, you also have to have workforce. And I think that also ties in with equity and access, because you can't have access if you don't have the workforce to deliver that the treatment. So with all this, Rwanda, in the limited resources that we have shown that it can be done. And I think these five policies align well with CSO, and I think with political will, strategic investment, and equitable coverage, cancer care is possible in LMICs. Thank you so much.
That's, so Fidel, I think you have cheered us up a bit, which is great. Questions? Yes, Renette.
Well, congratulations with what you have achieved. And it was nice to see on LinkedIn even recently that the new 3 medical oncologists really made the final hit, I would say, to work now. Where in your country is the biggest issue for workforce? Because is it only medical oncologists, or is it nursing staff or other staff to support you?
I would say that all the domains, whether nurses, we don't have enough oncology nurses, even surgery is the same. So we have issues everywhere, but at least it's not like we are starting from zero. We have some numbers, but they're not enough yet.
Yes, please.
Thank you. I just wonder whether you can unpack your meaningful benefit in your palliative patients. There are some medications, for example, that might be quite cheap and deliver a benefit compared to others that are more expensive. So do you have a way of deciding which treatments to give and which ones are not allowed? Can you just tell us a little bit more about that?
Yeah, so this was more on the policy level but of course, if the patient is able to afford some of these drugs, it's not that oncologists are going to stop giving them. But from the country policy level, they took a decision, and this is a disclaimer that I am not representing the government at all, but the decision was made that the CBHI is going to only cover first line palliative care. But if a patient is able to afford or they have private insurances, we give palliative chemo to whatever lines they can afford.
So Fidel, related to that, I think you said 50 drugs were added in your scheme. How did you decide which 50 drugs to add? Was this based purely on the size effect, the effect size for overall survival, or was it taking into account the cost of those drugs as well?
Good question, and it's both the survival but also the costs. For example, there are 2 drugs that usually could not be considered in such settings. For example, trastuzumab and rituximab, but we know that they also have good overall survival in some cancers. So these are already on the formulary, but the others that are not. And of course, we know there are also immunotherapies that are effective in some cancers, as Werner was saying, MSI high and others, but their cost is prohibitive, so we didn't add those.
Fidel, thanks. That was an amazing talk, and I think just inspiring because just full kudos to you and your colleagues for making this change in a relatively short time period. I mean, when you came to Kingston as a fellow, not that many years ago, you said, I want to have a system where we can provide drugs. We need to train our own medical oncologists. We need to improve access to palliative care. So it really shows what the power of a small group of dedicated people can do with you and your colleagues. It's inspiring. And my question for you, which is something that we could learn from in our own health systems with CSO, is to what extent did you involve civil society and the community and advocates and the media in creating this change momentum in Rwanda? And can you share some of the strategies and techniques that you and your colleagues used?
So because of Rwanda being a small country and also not many, not many patient groups, not many oncologists, not many other experts, I would say, big percentage of this, honestly, is a political will. This is what the government wants to do. And our voices come in as expert voices. And another thing is from the oncology side, this is at its infancy, as you can imagine. So the policy makers really hear us because we are, you find we are actually very involved in these decisions. For example, I would say if we are to do the national cancer treatment guidelines, most of us, are the ones that are doing them. So it's basically us doing it and the government, sometimes all policymakers endorsing what you're doing. So it becomes so easy to advocate for.
Eric?
Thanks, Fidel. That really was inspiring and it changed the mood. So thank you for that. I'm wondering if you can speak to changes within Rwanda parallel to the medical oncology that you've observed with surgical oncology and in your field of radiation oncology, because those are equally daunting problems.
Yeah. So I have to mention that 2 or 3 years ago, the government started an initiative called 4x4 initiative, where they envision training, quadrupling the workforce in Rwanda in all areas in the next 4 years. So that was 2 or 3 years ago. So almost, I think they're now going to look at the achievement. And this was not only in oncology, but across all the other fields. So back in for me, I joined the workforce in 2018. We were only 2 oncologists in the country. So right now we are 14. And that time we are clinical oncologists. So clinical oncologist, as someone here, I was saying, I basically radiation oncologist with a little bit of medical oncology. And so we found ourselves as like 8 of us, fighting on 2 machines. So that's when we said maybe we need to go away from the clinical oncology and just start medical oncology training. And that's one. So, and also deliberately, we started a surgical oncology program. So we now have a breast fellowship and colorectal fellowship. We are graduating 3 in each of these. We have also uro-oncology program starting soon, and also gyne oncology surgical program starting as well. I mean, it started already, graduated some oncology. So it's across all the workforce, I would say, levels that we are deliberately training workforce. Yeah. And honestly, this is not, though these are local trainings, but they are international standards. And also we do get, some of you have taught in my program, Scott has come to Rwanda, and others have, Bishal and others have trained our fellows online. So it is, and thanks to ASCO, actually, ASCO provides a lot of resources. My fellows do ASCO IT, and we do have access to SEP and also the question bank. So we have, a lot of collaboration international as well.
And it grows, right? I mean, the 14 you have now gives you much more potential for training the next 14 or 28 or whatever.
Yeah.
So that's great. Any last question for Fidel? Well, if not, thank you and congratulate you. So our last speaker in this session is Jennifer Miller. We've had a little bit from Jennifer already. She's the co-director of the program in biomedical ethics and an associate professor at Yale. And she has been directing the Good Pharma Scorecard. So we'll hear a little bit more about that from Jennifer.
Wow, Fidel, it's an honor to follow you. You've built such amazing work, very inspiring. So as was mentioned, Jennifer Miller, co-director of the program for biomedical ethics and associate professor in internal medicine and biomedical informatics and data science at Yale. which doesn't tell you at all what I do, which is focus on the ethics and patient centricity of the pharmaceutical industry. And in those roles, I run an initiative called the Good Pharma Scorecard. It's an index that rates and ranks pharmaceutical companies annually on very specific bioethics and patient centricity performance criteria. we founded the scorecard back in 2005. We started building it for a variety of reasons, but chief among them was I was a grad student at the time, and the literature on the pharmaceutical industry was and remains incredibly negative, right? The court coverage as well, telling stories about companies' ethics challenges, failures, and outright scandals, raging around concerns about companies' honesty and truth-telling, about the safety and efficacy of new drugs, concerns about marketing practices, to outright stories about price gouging. So if you step back, many of these concerns can be thought of as worries that companies prioritize profits before people. So while the literature and the media and the court cases are really good at bringing to light certain problems or perceived problems, they don't answer 4 critical questions. The first one is the prevalence of problems. It's entirely possible that the media and court cases are covering outlier cases, isolated problems, the product of an outlier company or a rogue employee, not a systemic problem. This is certainly what I hear a lot from pharma companies. Or it could be a rear view mirror problem, right? An old issue that as academics using old data are covering yet again in our paper. Again, I hear that's a lot from companies. And then if there is any genuine, current, and widespread problems, it's unclear what to do about them, how to fix them, and then what good practices look like. The literature and the media were so good at pointing out problems. We're really not so good at doing the upward counterfactual. What does the good look like that we want to see, and how do we know when it's been credibly implemented? And then lastly, how effective have our policy efforts been at curbing the ethics lapses or problems that we're trying to address? So those 4 questions inspired the founding of the Good Pharma Scorecard, which aims to do 4 things: set and communicate clear ethics goals for the sector, then evaluate and track progress on the goals, on the trial, on the product, on the company, and on the sector level year after year, to recognize and celebrate when there are best practices to show they're possible, but also to go in and study how did those bright spots do it, so we can develop generalizable guidance for the whole sector. And then importantly, to catalyze change where needed. We have 5 scorecards so far. 3 are actively launched. The first one is focused on transparency in clinical research. The second one on data sharing practices in research. The third on representation in clinical trial enrollment in oncology pivotal trials. The fourth one launching today is focused on access to novel medicines in low middle income countries hosting trials for their FDA approvals. And the fifth one, which is under development with metrics coming out this year, is focused on patient centricity across the entire pharmaceutical company. So before I dive into some of the metrics, is industry even paying attention? It's entirely possible we would build this and no one would care. So, it's in their CSR reports, their impact reporting, their ESG reports, their SEC filings, their CEO letters every year, when they score well. So they're paying attention. So what are we measuring? So I'm going to start with the first 2 scorecards focused on transparency and data sharing and research. So why did we start here 10 years ago? We prioritized here because at the time there was robust evidence suggesting a substantial transparency problem. This is one of the most well-known papers, but I think many of us in this room have published similar studies. This paper was published in 2015 in New England Journal of Medicine by Monique Anderson and Rob Califf. You all know who Rob Califf he was down at Duke at the time, and this banner study found that a year after a registered clinical trial, if you look at clinical trials registered in clinicaltrials.gov, a year after they're completed, only about 20% have reported results. And even if you look at 5 years after their primary completion date, only about half of registered trials have publicly available results. And we as a group recognized the critical importance of fixing this for 3 reasons: for patient care, for the quality of medical evidence, for innovation, and for honoring and protecting research participants. Medically experimenting on humans is ethically justified by the potential to contribute to generalizable knowledge that can advance human health. When we don't put the results of a trial into the public domain, the entire ethics of the clinical trial comes into question. So what are we measuring in this area? 5 humble things, because we'd like to measure a lot more. We're looking at whether a trial is registered in any registry like clinicaltrials.gov, whether it has results reported in any registry, whether it's published in the medical literature, whether it complies with US legal requirements for trial registration and results reporting enshrined in Fidel and the final rule, and whether a sponsor commits to a series of data sharing measures. Again, we're humbly only looking at trials supporting FDA approval of a novel drug and a novel biologic. We're looking at all trials supporting a product approval, so that's all trials in an NDA or BLA. Then we look at a narrower sample, just trials conducted in patients for the approved indication. And then a still narrower sample, just trials highly likely subject to legal requirements for trial registration and results reporting under Fidel and the final rule. So we've been benchmarking for a while, but how are we scoring on transparency metrics today? You're getting a sneak preview of the scorecard that's going to come out soon. So the good news is for the first 4 cohorts of evaluations, and this is just large companies, I'll show you all size companies in a second, the trend was going in the right direction, right? Improving, which is what we wanted to see. And so the question is, with the new scorecard that's coming up, does the trend continue? What do we think? Yes? No? Interesting. So here's the new sample. It's looking at novel drugs and biologics approved by the FDA between 2018 and 2021. It's 208 products sponsored by 136 different organizations. Interestingly, we have some nonprofits in there this year for the first time. It's not all industry sponsors. For a variety of indications, most commonly oncology. These products are approved based on over 1,000 trials conducted in over 330,000 patients around the world. This is the first cohort where the transparency declined. Now, this is not a statistically significant drop. However, if you look at the matched sample, so the companies that were in the last cohort with the matched companies in this cohort, it's a statistically significant decrease. We did stop benchmarking for a while because we were building the other scorecards, but the question is like, why is this dropping? And so how is the whole cohort, all of the 100 and something products scoring? So let's start with the good news. If you just look at trials conducted in the patient population for the approved indication, we're doing pretty well. 95% of those trials are registered in a public registry and 85% have public results. But I'm measuring at 6 months post FDA approval of the indication. That's a pretty generous measurement. A lot of payers are deciding much earlier than that, their coverage decisions. So 70% of results are reported on clinicaltrials.gov and 60% are published in the literature by 6 months of FDA approval of the indication. The bad news is that if you look at all of the trials in an NDA or BLA, only 50% have public results. So that number is still hovering around the same as Califf and Anderson's paper back in 2015. 37% have results reported in a registry and 23% are published. And then if you look at FDA compliance, only 62% of applicable trials are meeting baseline legal requirements for transparency. And if you flip all and you roll it up to the company level, about a quarter of companies share the results of all of the clinical trials supporting their product approval. So it's definitely possible to do that. However, on the flip side, only 32% of companies meet baseline legal requirements for clinical trial transparency. So 68%, 68% of sponsors fail to meet legal requirements for all of their trials. That's a really high number. I don't know whether the FDA knew I was giving this talk today. I'm obviously kidding. But yesterday, the New York Times covered that the FDA is going to be addressing FDA implementation, and they issued a series of letters to drug manufacturers who they think are non-compliant. They only sent 2,200 letters. I believe they need to send a few more. But I'm excited to see what that does. And so when we get companies together, what do you think their talking point is? Any ideas? This is all the fault of the non-large companies. You know, if you just looked at us large companies, you'd see how well we're doing. So it turns out, you know, in overall transparency, there's no, it's not FDA compliance, it's not patient trial availability or all trial availability, but there is a statistically significant difference on data sharing procedures between large and non-large, but not on any of the other measures. So what are we looking for data sharing? I'm not going to go through all of them, but the number one thing is that a company has to have a public policy committing to data sharing. And then we're looking at, you know, does it also report the number of requests it gets for data and how they were handled, were they approved or not approved? But the big takeaway is that more than 60% of sponsors don't even have a public commitment to data sharing. So we have a long way to go in this space. However, on the other side, almost 20% are meeting all of the measures that we're looking at for data sharing. So again, it's definitely possible to meet these measures. The other thing is, I mentioned this earlier, when we have the resources, we give companies an amendment window, so 30 to 60 days to improve procedures, and we publish a pre and post score. And so here you can see how that works for data sharing. You know, we published our first set of scores, and you saw that only about a quarter of companies met our data sharing measures. And then when we gave them, and the median score was 63%, and we gave them the amendment window, you can see that half of the large companies took us up on the opportunity to improve things, and the median score went up to 80%. And then overall, if you look at companies' scores, I'm happy to say that 8 companies on the forthcoming scorecard, again, you're getting a sneak preview, tied for first place and scored 100%. So these would be your bright spots for this sample. And another 24 are going to be getting a gold rating, scoring in the top quartile on transparency. So that's a really high, quick overview of how the transparency measures work. Let me give you an overview of the representation and research measures. Again, we started looking at this because there were so many studies suggesting a robust problem that we tend to, women, older adults, racial and ethnic minoritized patients are consistently underrepresented in oncology research, right? We tend to test new medicines and vaccines on healthy, young, white males that don't represent patient population with a targeted indication. And we know that this is a problem and critical to fix for the generalizability of clinical trial results so that everyone has a fair opportunity to participate in research and for trust. When clinical trials are unrepresentative of the patient population that will use them, those patients and the clinicians are less likely to find trial evidence relevant for their care. So here's the ROI, if that's what you're focused on. They're less likely to believe a drug will be effective for them, and they're less likely to use the medicine. When the clinical trial is more representative, the trust gaps close. So these are sort of incentives for pharma companies to address these issues. We have 40 years of policy efforts in the US trying to improve representation in research with limited impact. And now arguably we don't have a lot of federal support, if any, on this topic. So we decided to tackle this with the Good Pharma Scorecard. We always follow the same process to develop our metrics. We do a literature review, a guideline review, and then multi-stakeholder engagement, interviews and focus groups with patients, clinicians, and other stakeholders, and then a bright spot analysis if we can. So for representation, we're looking at three things. The first one is, can we even tell some basic demographics about the participants of pivotal trials supporting novel product approvals? Then we're looking at how representative they are of the patient population in the US with a targeted indication. And then fair inclusion is, was the trial both transparent about the demographics of trial participants and representative of the US patient population with a targeted indication? And we're looking at 7 transparency measures and 5 representation measures. Need to look at a lot more, but this is where we started. So what are we finding? So we piloted these metrics on novel oncology products approved by the FDA between 2012 and 2017. That was 59 novel oncology products sponsored by 75 companies for a variety of oncological indications. Total of 64 pivotal trials, median of 1 per product, with 30,000 patients enrolled around the world, a median of 326 patients per pivotal trial. So the good news, reporting on sex is high on the trial, product, and company level. It's 100%. However, reporting on every other measure that we looked at is poor. So age, proportion of older adult participants, racial and ethnic identity of participants, substantial room for improvement. And representation of every group needs improvement, including women. However, one company scored 100%, United Therapeutics in the pilot, which is interesting because UT is a public benefit corporation. They started in 1996 and then in 2021 became a public benefit company. Just an interesting observation. Additionally, some companies scored 100% on different measures, again, suggesting that there might be bright spots and that it's possible to do this well. So we got a grant, applied for and got a grant from the FDA Oncology Center for Excellence through the FDA Mayo CERC program to expand our sample to more than 10 years and to see if we could find bright spots, consistent high performers, so that we could go in and interview them to see how they thought that they did it. And we published the bright spots analysis, finding them in JCO OP. And so we looked at 111 novel oncology products sponsored by 70 different companies based on 121 pivotal trials, and we found 31 bright spots. 19 of which were sponsored by a large company, and we went in and interviewed them. We found 14 factors associated with success, which I don't have time to go through, but these are processes likely to drive that outcome that we're looking for. And so we're thinking of adding these leading indicators into the scorecard to drive that outcome, right? Adequate representation in a trial more quickly. So again, now the new scorecard's coming out in this area. Do we think things have improved, got worse, stayed the same? Anyone think things have improved? Interesting. Got worse? Bunch of pessimists, might be because it's afternoon. Stay the same. Okay. So everyone's sort of right. Transparency has improved. We are much better, statistically significantly better at disclosing the age of of participants, the proportion of older adults, and the racial and ethnic identity of participants. So that's really great. However, the bad news is we have not improved representation yet for any group, which is why we're going to try to add those leading indicators to drive that outcome that we're looking for into the scorecard based on the bright spot analyses. And then wrapping up, the forthcoming scorecard that we have is focused on access to medicines in low middle income countries, hosting trials for FDA product approvals. So back in, I don't know exactly when, maybe 2021, we published a study in JAMA Network Open, and we just had 2 simple questions. Where are the novel drugs approved by the FDA tested on the country level? And what are those countries getting in exchange for participating in clinical research? Do they get physical access to the products they help test? And physical access was defined, again, really humbly, as just a sponsor submitting and receiving marketing authorization for the product in the country where it was tested. It doesn't mean it's affordable, there's enough supply, or that there's delivery. It just means that it's commercially available, physically accessible. So in this pilot study, we looked at products approved by the FDA in 2012 and 2014, just focusing on those sponsored by a large company, defined as the 20 largest by their market caps. So it was 34 novel drugs sponsored by a variety of companies based on 898 trials. These 34 drugs were tested in 70 different countries, only 7% of which received physical access to the products they helped test within 1 year of FDA approval. And even if you look at 5-7 years after FDA approval, only 31% of countries had market access, physical access to the products they helped test. Unsurprisingly, high-income countries had better and faster access than lower middle or than upper middle income countries. I think if I break this out by geographic region, you will not be surprised by the answers. So here you can see that unsurprisingly, Canada, Eastern Europe, and Western Europe had 100% access or near 100% access to the products they helped test. Whereas Africa on the bottom had 0% access, but they hosted trials, right? So they're hosting clinical trials. They're not getting physical access to the products they help test. This is, I'm going to use the word, it's arguably exploitation. So I presented this data at a panel. Industry was on it, and what they say, this is a rear view mirror problem. You academics use old data. If only you updated your study, you'd see that this problem has been fixed. So, like a good empiricist, I did that. And what you see is we looked at 172 products tested between 2015 and 2018. It's still old because you have to give 7 years for the product to reach the market. So it's sponsored by 75 different organizations. And here you can see that these 172 products were tested across 89 different countries, a median of 16 countries per product, most high income, 55%. However, a substantial amount of upper middle, lower middle, and low income countries. And do you think things have improved? Oh, now we're pessimists. So again, we have very high access in Western Europe and Canada, but interestingly, not 100% this time. And then still the lowest access is in Africa. And is access improving? It is for high income countries. And in some areas, it's dropped. So it's not improving overall for upper middle or lower middle. And it's dropped in Asia, statistically significant, and dropped in the Middle East. So now we're adding this to the scorecard. So now you're going to see the companies. We've done this twice now. So after we've done it twice, we start to name and shame, and we name and fame. So this will be coming out the scorecard. And then we're also, if you look at the appendix of that paper that came out, all of the country performance scores are in there. So you can see, the median time it takes for a product to launch if it launches in a country and how countries are comparing. It turns out that some countries are able to consistently secure access to products they help test for their citizens. And so we're launching YMAN, Yale Medicine's Access Network, to twin the bright spot countries with the ones that need to learn the practices together for a knowledge exchange platform. So that's it. We have 3 scorecards, 2 in the pipeline for this year, and we're just slowly layering, ethics and patient centricities every year. There's so much more to do, but thank you so much.
Thank you, Jennifer. Questions? Oh, Sam?
Thanks very much, Jennifer. Sam Stevens, CSO Fellow. My question is about how you deal with the problem of pluralism when you're doing your stakeholder engagement. I imagine a lot of different views come up when you're deciding on which metrics to add to the scorecard. How do you deal with that problem in practice?
So I don't know if I didn't highlight it, but we take a tiered approach, right? So there's a floor below which no company should fall. So if you think about the transparency measures, it's the law, which you can see we're having even trouble meeting that floor. And then we have a middle ground where most sponsors are probably going to be able to meet those measures. So if it's the transparency measures, it's disclosing the results of trials in patients with the approved indication. It's a really small set of trials. And then we have an ideal, which only some companies are meeting, which is disclosure of all trials, or now that's evolving. It's sharing data or returning plain language summaries or something like that. So it's less of a negotiation and more of a spectrum of performances that we try to capture in the scorecard, from the floor to more of an ideal.
Felipe?
Yes, compelling numbers and data. Really, thanks very much for framing us. Just a question regarding the last data that you presented. As we come from low and middle income countries, some pharma companies, they just submit for approval later on, so they wait a lot because they know the market is more appealing in high income countries. So if you decompose that data that you showed, perhaps as far as I remember, 12 years ago, I did this in Brazil, and 45% of the time was related to the delay in industry submitting. So this data should be decomposed. Do you have any sense how this behaves now? And the second question is related to the value based of these drugs. So as we know, FDA just the role is about approve it based on safety, efficacy, whatever efficacy they believe is. But in this regard, my question is, if we could decompose again for high value-based drugs like high MCPS scores, we know that for high-income countries, they approve faster and perhaps the likelihood of being approved is higher. So if you decompose this also, the data that shows follows the same idea for low-income countries.
Yeah. Let me tackle the first question. So we've only measured up to 7 years post FDA approval, but there was no significant change post 5 years. So I'm not expecting to see a ton of products surprisingly submitted after 7 years. And of the other studies that I've seen around this, I haven't seen anything, but it's entirely possible. And since we have the data, we could go back, from the 2012 and see if 13 years later, if we found any changes. I don't anticipate that, but I really would be happy to be wrong in that area. And then your second question is a really great idea, and I'd love to work with you to follow up on that.
So last question from Manju.
Yeah, very nice work and really happy to see this happening. Regarding, when you said approvals, one is approval, second is access. It's never equivalent. So even though, those drugs get approved in a country like ours, but that doesn't, ensure access. The second thing is that, when we say Africa, meaning this is from some little work which we did in hematological cancers, most of the times it's South Africa which is part of the trials. I don't think there are other countries which are participating. So, and the third bit is, when they open up trials, most of the times in the low middle income countries, it's towards the end. And it's largely because the accrual has been slower and they're not able to meet their target. And that's the time when they reach many of these countries. So is there anything, in your analysis as to when they approach these countries, and how many other than South Africa which were part of these trials?
Yeah, so I heard 3 questions. Or one was a statement that access obviously is far more involved than commercial access, physical access to a product. I completely agree. And that's why now we've been interviewing the ministers of health and the heads of the oncology centers systematically across countries in Africa and Pakistan. We're moving slowly to the other geographic regions to understand first barriers to securing commercial physical access, and then secondarily the barriers to securing other forms of access, supply, procurement and all that. We have completed a lot of interviews and we're still going through the data to see if there's any measures that we could build into the scorecard. Really welcome you to get involved if you'd like. Where in Africa, there's there were a substantial number of countries in Africa where we run clinical trials beyond South Africa. But if you look at the appendix in that paper that came out in January, you can find exactly the number of trials in each of the countries by region, and not just Africa. You can look at any country. And South Africa, I remember in particular, you're right, I think the highest number of clinical trials and secured physical access to 34% of the products that it helped test. And then I haven't looked at when recruitment starts by country, and I'm not sure I could find that from public sources, but that would be interesting. Yeah, thank you.
Okay, well, I think we've had a very good and a very mixed session, and I thank all of the three speakers, and thank you everyone who's been listening in online.
Great. Thanks, everyone online for joining this virtual plenary session. We'll close this portion of the session. Very grateful for everyone participating, and stay tuned for those live here in Montreal.